the various platforms for UDST, which are currently in use across districts, which test to prioritize in which scenario, and of course I'll share few of the findings from our study and few of the findings from the recently held National Task Force meeting, which was held last month only in Ranchi, so, related to UDST only. See, the battle against tuberculosis is like Behra sir said, it's almost now more than 50 years. We started to chase the bacilli since 1992, but it's almost more than half a century that we are trying to tame this bacilli. And on one hand, we are saying TB harega, desh jeetega, TB mukt bharat. But what the bacilli says, you have to listen to the bacilli also. That bacilli says, jab tak suraj chand rahega. So it's a fight between these two, cat and dog fight is going on since centuries. And if you see from the scribes, Indian literature has reported about TB, say roughly 300 years back. Chinese literature has reported almost 2000 years back. But if you see, the first case of TB in Indian mythology was reported 9000 years back. So it's an ancient disease. And it's in 1834 when Sean Lane talked about or termed this terminology, tuberculosis. Later, Robert Koch identified the bacilli. And since then, we are trying to understand that red color bacilli, what is this nature and how it behaves with us. The more we are getting smart, this bacilli is getting smarter day by day. And from my undergraduate days, guidelines have changed. Every now and then it is getting changed. By the time we learn about the treatment modalities and we start, training our field staff, again a new treatment guideline comes, new test comes. So in fact, the bacilli is keeping us confused every time. But we have heard that we have done a lot. Yes, of course we have done a lot, but then the gap is also a lot. We are dealing with 150 crore population, and that means the problems is huge. So we have seen that how much we are contributing. We have reduced 21% reduction in incidence, and we have treated lakhs of patients. Recently we had through chest X-ray, we have screened almost more than 22 crore population. We have identified so many lakhs of population newly diagnosed TB with just handheld X-ray. That means just a simple procedure with handheld X-ray, and we have screened just 15% of population, and we got so many percentage of new cases. Imagine if we screen entire population, then how many cases we can get? It may be more than 1 crore new cases, and that tells the story, the burden of tuberculosis in our country. Now, if we talk about the MDR TB, see, one TB patient, if he is untreated, can infect roughly in a month another person. If he is untreated for 1 year, he can infect another 10 to 15 patients. Now imagine the same happens with MDR TB patients. Now this MDR TB patient, which we know is difficult to treat, they can actually infect in a year another 10 to 15 persons with that MDR strain. So one MDR patient can give rise to another 10 to 15 MDR patients, and that is where the problem is, and that is where we should discuss about. Now, if we look at the global share, there are two data which I have found. The ICMR says 27%, whereas the WHO report says 32%, which India contributes to global share of MDR TB. Now, just in the 2022 data says, India data says that out of 1 lakh population, we have roughly 316 MDR or XDR TB patients. It's a mathematical modeling. In same year, actually, why this is based on the fact that in same year 2022, India reported 60,000 MDR or RRT because of rifampicin resistant cases and nearly 11,000 of pre-XDR or XDR TB cases. So that is 11,000 patient. Mark this, 11,000 into 12, you can count on every year. Now, as we know that old treated patients are more likely to be MDR TB. This is simply because they have more chances of defaulter, and they give rise to the resistant strains. This is just recently published in Times of India, and this is data based on ICMR data only, and WHO also has shared this data with India. And this says that there are 30 high burden countries which harbor 87% of TB cases, and in that India tops. So somewhere India is topping also with 25% global TB cases. And if we come to the same thing, that only 4 countries share the more than half of the cases of MDR TB cases, and in that again India is 2/3 cases of are just from India. And you see here China is at 7.1. With equal population, China is contributing to 7.1% of MDR cases, and we are contributing to 4 times MDR cases compared to China with almost the same population. Now, this is one of the study which we did with TB patients. We did a study with TB patients, 376 TB patients, and we did some qualitative interaction with the TB patients and their family members, relatives, and caregivers. So they said they gave various situations, because in morning we also had a story of how Nandish ji shared that how TB is still a stigmatized disease. This one patient I'll just highlight. This 42-year-old patient, when we interviewed him, he said, "Sir, I was having symptom for more than 1 year, and at first I visited private practitioners, then multiple of private practitioners, then even physicians, multiple physicians, and none of them advised me sputum microscopy. So I was doing chest X-ray, and everywhere I was diagnosed as COPD, and he was on inhaler. And then he went to somewhere, some pharmacy store, then he went to even Silchar in Assam. He went and he got treated there, and he came back. And then he was sitting in my room, in my medical college room. I am a community medicine department faculty. He was sitting in my room with 4 of his other family members and his driver, and none of them were wearing mask. And then he said, "Sir, should I go for sputum microscopy?" And we sent him to sputum microscopy. It was positive. So he was traveling for last 1 year from post to pillar, and none of them even suggested him sputum microscopy. To add to that insult, he turned out to be a MDR positive. So that is the story which I want to highlight. And in this study also, most of the things, people have less understanding about tuberculosis. Out of these patients, these are the TB patients, and they are under treatment. So they are still confused how TB happens, how they got TB. So these are the questions we still need to communicate with the community, because you can be sure of that people who know about TB are very limited. The mass, 99% of the population are stigmatized of TB because they do not know the pathophysiology of TB. That is the problem. We often say people do not know, but why they do not know? Because they are unaware about the facts and the processes. Second is diagnostics and care seeking. Many of the times doctors are exploiting the patients. I must agree to, say this. I want to highlight this, because many a times they go to private practitioner. Patients are scared to be diagnosed as TB patients. Nobody wants to be diagnosed as TB patients, believe me. So they want that sputum test should turn out to be negative. The X-ray should be turned out to be negative. They want that the diagnosis should be COPD. They do not bother about that, but least tuberculosis. And it is very difficult to convince that you have TB. Once they you show them the report, they show after treatment, they show signs of improvement, then they agree that yes, I am having TB. Then after that, once the patient is on treatment, what we have found is once they are on treatment, the TB caregivers, DOTS providers have very good relation, and once they are cured, then they become actually the the messengers of our dots. So it is very important that to bring them into the mainstream of treatment as early as possible. I'm just, after this slide, I'll go to the UDST part. Now, this is the finding from our study from 376 patients. Average time from symptom onset to diagnosis was 47 days. And from diagnosis to actual treatment, full treatment, many times drugs are not available. The patient is from distant village. He has to come to the medical college or sometimes to the referral hospitals and then get the treatment, and he has to be referred out and again go to the ASHA. ASHA needs to be the dots provider. All these channels need to be filled. It's not that he got diagnosed and next day he's is on treatment. So this is 26 days, and if you calculate this, it is almost 2.5 months. What I mean to say, symptom to treatment initiation is 2.5 months, and as I said, by this time he must have infected another 2 to 3 patients. Now what is happening in between is, we are giving drugs. Of course we are giving drugs. Our intention is that, but what is happening if there is resistance? There is a bonhomie between the AKT drugs and the bacilli, and within slow process this is what happens. 3 लोगों को जान नहीं पाए, एक भगवान, एक जिनके साथ हम संसार का मतलब घर बसाते हैं, और तीसरा है टीबी बैसिलाई. तीनों को समझना बहुत मुश्किल हो गया है, बड़ा मुश्किल हो गया है एकदम से. Now already has been published that INH resistance settles earlier than rifampicin resistance, and by dictum we say when there is rifampicin resistance, it means INH resistance is also there. But the problem is about only INH resistance. The data shows that 17.3% of the patients we put on treatment are INH resistance, and roughly the meta-analysis says from 1130 studies a meta-analysis has been done, and this study shows that 7.2% patients are both INH and rifampicin resistance, which means 10% patients we put on treatment are only INH resistance, and our TrueNet and CBNet does not detect that. So these 10% patients we put on treatment are actually getting treatment who are INH resistance, and they are getting INH drug in routine process. So UDST means universal drug susceptibility testing, we all know that, but then UDST is only possible when there is a biological sample. A patient who is not producing or where biological sample is not possible, UDST is not possible. So a patient who is diagnosed based on only clinical suspicion or X-ray or any other methods, we cannot do UDST. But the good thing is that they are not going to spread the disease. If there is no biological sample, they are not going to spread the disease, most probably. But there is a possibility that they are not producing sputum, but yet they can spread the disease. But by and large, we can expect that if they are producing, UDST possible. If they are not producing, UDST not possible. We are on strong clinical suspicion of starting treatment or based on X-ray or otherwise. So every patient, the current guideline says, every TB patient must undergo a rapid diagnostic test, at least investigated for rifampicin resistance, considering that INH and rifampicin resistance is there. Now the current policy says, test all newly diagnosed TB patients upfront CBNet, including those in the private sector with an upfront CBNet. But the data says from private sector, 50% of the patients are not going for upfront CBNet. So there is again missing, we need to partner with the private sector again. Eligibility, if you talk about the UDST policy and the guidelines, Government of India guidelines, NTBA guidelines 2025, all notifiable cases, whether they are pulmonary, extrapulmonary, they are private, government, all ages, including pediatric TB, including contacts of drug resistant TB cases, all are eligible for upfront CBNet. UDST must be performed before starting the treatment, and I will show you from National Task Force data in which zone, how many percentage of patients have been put on upfront CBNet or UDST. If it is not possible to start, do UDST, before the treatment, at least within 15 days, because after that INH resistance immediately settles into rifampicin resistance. So then if a patient is on, or the bacilli is INH resistance, you actually get, after 1 month you get both INH resistance and rifampicin resistance, and then after 2 or 3 months when you again test the patient on follow-up, you find that now he is both RIF and INH resistance, not only just mono resistance. Again, NAT, TrueNAT or CBNAT, I'll show you what is the difference between TrueNAT, CBNAT, GeneXpert and LPA. To be used in initial diagnostics for all presumptive TB cases also, whether pulmonary, extrapulmonary, adults, children, high risk contacts. Let's skip this slide. Yes. So this is how a TrueNAT looks. It is used for the periphery. You can pick it. It is battery. It can be used with battery also. It is a two-way process. On one way you extract that DNA. On another side you put the PCR amplification. And it is usually on one module or 4 module. So it is basically for small sample size or in periphery. This is how GeneXpert or CBNAT looks. It is a bit heavy machine. You need a central a room. You need AC backup mostly, and the principle is you put the sample inside and the report comes. So you have to discard the the cartridge. So this is CBNAT. This is line probe assay. So this is a 3-step method. From here it starts. The molecular testing or the drug testing actually starts from here. Your TrueNAT and CBNAT only tells about rifampicin resistance, but actual molecular testing starts from here for all the drugs in line probe assay. And in MIGIT, this is actually looking into bacterial growth and then the drug sensitivity. So we are looking for line probe assay or MIGIT or other recent advancements regarding gene testing which are in pipeline. You have next generation sequencing, GeneXpert, MTB-RIF Ultra, whole gene sequencing, Expert MTB, host response, MTB HR you said, and loop mediated isothermal amplification, that is LAMP. These are the all recent guidelines under the CTD division which are in pipeline. Now, when to use what? If you want TrueNAT and you have GeneXpert or CBNAT, you can get rapid molecular TB diagnosis at medical college or at PHC level, district hospital level. You get rifampicin resistance, which means INH plus rifampicin resistance, and you can use it for all presumptive TB cases. And then LPA, it is for first line and second line. It detects all sorts of drugs resistance. Now, when we go for LPA, when we see in NAT shows that MTB is detected and there is a possibility of resistance, we go for LPA testing, and it is for first line and second line resistance. Now, MIGIT culture is the gold standard at present. Mostly in medical colleges have MIGIT, I believe. Most of the medical colleges, at least the government medical colleges have. It is for drug susceptibility and it is non-molecular. It looks into bacterial growth and then looks into the resistance. It is basically done from MDR or XDR TB cases when we find it from CBNAT or TrueNAT resistance. Now, if you look at the comparison for various UDST, sensitivity, if you look, TrueNAT is high, GeneXpert is very high, LPA you get all the results, and MIGIT you get all anti-TB drugs, including not only just first line, second line, injectables also you get. So we look into the sensitive pattern, but if you want rapid reports, you should go for TrueNAT or CBNAT. You want to start treatment immediately, go for TrueNAT or CBNAT. If there is resistance, then go for LPA or MIGIT. Utility wise, TrueNAT can be carried anywhere, practically anywhere. You can go to villages also, but CBNAT you need specialized center, medical colleges, or at least district hospital level where you have continuous power backup supply. LPA and culture, of course, reference hospitals, reference medical colleges, reference laboratories you have. TrueNAT, the advantage is it's damn cheap. And for LPA, you need BSL 2, BSL 3, then those things. Now coming to the the National Task Force report. I have highlighted East Zone here. The findings from, as reported from all the states in East Zone, all the states by all the STOs, STF chairperson, every data we have taken from medical college, and what it says from East Zone, where we are sitting now, diagnostic capacity constrained due to limited first line probe assay and second line probe assay and culture DST facilities affecting UDST implementation. And the recommendations were, which should be a contributing point to this policy conclave, is expand first line LPA, second line LPA and culture DST services to strengthen DRTB care in the East Zone. If you look at the South Zone 1 and South Zone 2, UDST coverage exceeds 90%. If you go to North, they are doing bit better, but then not up to the mark of the South districts, but East Zone and Northeast Zone are doing it not up to the mark. So we need to expand UDST in these regions. To summary and to take home messages, all TB patients are now eligible for UDST, which is the foundation for National Tuberculosis Elimination Program's TB elimination goal. NAT, whether it's TrueNAT or CBNAT, is the now upfront CBNAT is now cornerstone of diagnostic. LPA and culture remain essential for mapping resistance. You cannot map your resistance pattern, the type of bacilli, the type of resistance, which age group, pulmonary, extrapulmonary, pediatric, old age patients, old cases, new cases, you cannot map without LPA or DST labs, but CDST labs. If you are looking for resource prioritization, then you should look for TrueNet and CBNet. But if you want to you are looking for gene expert, resistance, DRTB care, then you should go for LPA and UDST other things. I think that will be all from my side.
Thank you, sir, for a nice deliberation. Just a few points I want to add what you have learned from your presentation. Say, presently in Odisha, sir, we have 3 labs, particularly as regard to culture lab is concerned, and recently also we have new one medical college, old medical college having also culture lab as well as LPA lab. So based on our data, it has been seen that rifampicin susceptible test in our population, notified population around 95%. What I mean to say, it depends upon the denominator. What I mean, if you calculate the denominator means out of all microbiologically confirmed tuberculosis, then only we can do the sensitivity test. That is around 95%. Yes, we have some of the challenges like as because we have a high burden LPA burden in our state. That's why we could not do the LPA. So turnout time little bit longer. Instead of probably we used to take probably around 2 weeks to turn out that time. But definitely, you just analyze one of the fact that you might be agree with me. Rifampicin is not only the solution to identify the drug susceptibility test. Out of that, other drug important also simultaneously. As being a clinician, I also important same point of giving the emphasis. Both rifampicin as well as INH in first line is very much important as regard to drug susceptibility test is concerned. So important here that we are getting very delay report due to the lack of infrastructure. We are also trying hard. We have one of our colleague also, state TB officer. He will give some a remark also.
So good afternoon. Actually, the number of cases we notify in our state, as you are mentioning the incidence rate of our state, it is not that we are identifying all cases. Incidence rate in our country is more than 300. In our state, it is 295 per lakh population. But the notification, if we will find in last 3 years, is grossly around 60,000, which is close to 128 per lakh population. That means we have some gaps, some challenges in identifying TB cases. that might be due to some regions has been highlighted by that prevalence survey conducted by ICMR that says that, as you have rightly told, that TB cases, when they get diagnosed, they think that they were not having TB. 67% of TB cases, when they get diagnosed that they are having TB, they say that we thought that we are not having TB. Similarly, 40% cases now they say are asymptomatic in nature. They get diagnosed by radiological means and they are not having any symptoms. So either you don't get sputum also to get it confirmed in microbiologically. So these are two bigger challenges we are facing now, because unless you identify all the asymptomatic TB cases also in the community, but he has already told that they may keep on transmitting that disease if they are having that pulmonary TB. Second thing is that the important part is that the drugs UDST part. We have capacity at block level and sub-block level to identify rifampicin resistance, because we have lot of those TruNat machines, and TruNat machines two-stage procedure. Yeah, first you identify MTB, and you then, if MTB is detected, then in the next step you confirm that whether it is a reef resistance or reef sensitive bacteria. Problem then comes that the actual problem of identifying INH resistance, because as we are identifying 60,000 cases per year, so all these 60,000 cases needs to be examined for INH resistance also. So for that we have limited capacity. As he has rightly said, we have established one more laboratory recently in Bhimsar Medical College in Bulla. Prior to that, we have two laboratories. And from that two laboratories, from our side, from program side, we have one laboratory dedicated for our state program, that is the intermediate reference laboratory located inside SCB Medical College. And the second laboratory we are using is the national reference laboratory for northeastern states. It is actually not a reference laboratory for our state, but still they help us in doing test for first line LPA for 10 districts of our state. So there is a limitation. So because it's a limited capacity, the turnaround time for getting the reports is also very long. So many a times it happens that when the treatment starts with DSTB, because that person is having rifampicin sensitive, by the time the result comes for first line LPA, the treatment is over. So these are actual operational challenges we are facing, and it is not limited to our state, pan-Indian problem. It is a pan-Indian problem.
Now we'll request audience, anybody want to give some comment or any query?
Thank you, Dr. Shiv, for that excellent talk. I had a not exactly related to your talk, but a related question. How is TruNat being used in the periphery where the DNA extraction? Are lab technicians in the program capable of doing this DNA extraction as the first step before the PCR? So is it being effectively used? Because as per the program the ICMR has provided to every district, but how effectively is it being used? So just
That I'll tell, madam. The government mandate is to provide TruNet to even the subdivisional hospital, and they aim to even at PHC level. But the problem is, from most of the, at least in Northeast, in most of the subdivisional hospitals, the TruNets, and even at certain subdivisional hospitals, the CB nets are lying like that only. Now, problem is that the CB net machine has been installed, but there is no reagent. Sometimes there is reagent, but no cartridge. So often to fill the gap, from the district headquarter or from the state headquarter, a mobile, NAT van is sent, and then the test is done. So to answer your question, many of the TruNets are just lying in packets. CB nets, many of them are underutilized. And for example, we are a very small state. I'm from a very small state where reporting per year is just 3,300. Compared to Assam, which is a bigger state, their reporting is per year is 52 to 58,000, in that range. So for my state, 65%, I'm talking about the smaller states, 65% of the patients are being diagnosed by the medical colleges, and only 1/3 of the cases are diagnosed by the district hospitals, that too simply on sputum microscopy. And TrueNet and CBNet is either not done or just done as a backup to the sputum microscopy. So that is the reality. So that means that training or the staff is also limited. So not just providing that machines is important. How much these are getting utilized. Now there is a from the in every state, from the STO side or from the program side, we often tell the lab technicians and that either you use it or you will take it back from your PHC or subdivisional hospital. And their answer is simple: we never wanted it. You only pushed it to us. So you take it back, because that is an additional burden to us. And also we are not getting so many patients. So like sir said, there is a lot of gap. And that gap is, that gap is an estimated gap, I would rather say. What is the gap, we do not know. So we estimate the gap and we give mandate to the PHCs, to the district hospitals, that you have to fill the gap. And now they are in a fix from where to fill that gap. We do not find cases and we say we are not getting cases. So there is a always a tug of war between the program and the peripheral worker. We want more patients and they say we are not getting patients. Now this has been an issue with this X-ray drive. We have got so many patients. So then we said, see, there are so many patients, and their answer is, sir, these are X-ray positive patients. They are not symptomatic patients. So this debate goes on. So the machines are very much underutilized, and we need more manpower also for these machines. So like Behra sir was telling, the non-technical part you have to take care of. The reagents, the cartridges, the manpower, everything is there. I think.
To supplement, madam, to his answers, actually in our state, because now we have shifted from microscopy to NAT for these upfront samples. We only limit our microscopy for only follow-up samples, because as Behra sir was telling that you may get a false negative result in case of a follow-up sample if you put it in NAT. So we limit it only for follow-up samples. We can do it in microscopy. So all our upfront samples, probably highest among the larger states, we are doing in this NAT. So for that, for the quality to keep the quality high, so we have introduced EQA system for NAT also in our state. We engage our microbiologist of all DPHLs, District Public Health Laboratory. Now they are gradually converting into IPHL, Integrated Public Health Laboratory. So microbiologists are being trained at our ATDC for this EQA activity, so that they will take care of all the NAT machines in their district for that local EQA quality assurance.
Anybody from the audience, anything? Okay. Next, what I think, sir, yes, in our state also, you discussed that 80% of cases usually identified by the non-medical institution, non-medical college. So as regard to notification is concerned, around 20% or 22% of notification case from medical college itself. So that means we have to think of a mechanism where we can do both, not only rifampicin, in addition to that other first line and few important second line drugs, susceptibility test at a ground level, so that it will be a good impact to the program also. Okay. Yes, sir.
Excellent talk, sir. Just one question. Since we are focusing on NGS, so the problems which we have discussed now, so regarding the delay in diagnosis and also, what is your opinion regarding the NGS in such cases? Is it going to be, fill in the gap for this? If we try to bring in NGS, NGS, okay, okay. Is it going to fill in the gap?
Sir, the gap, next gen sequencing is not the answer to the current gaps which we have identified. The current gaps are there only. We need to take extra effort to fill in those current gaps. Why patients are coming, say, to roughly 2.5 months late even after symptoms on an average. Some patients come after 7-8 months, like sir said, 1 year after. Also so many patients come to for diagnosis. After treatment, then again sometimes there is shortage of drugs and all those things. So these things are from ancient days. These things are from since RNTCP started. What next gen sequencing is going to add is that this resistance pattern, the gene sequencing or the molecular testing is UDST in other sense, is going to take care of that resistance. Why? Because I believe every sputum is a story, and every UDST test is a hope for that story. Now, you cannot win this battle against tuberculosis only by drugs. You need community mobilization, correct diagnosis for the correct patient at the correct time, and then only it is possible to provide that patient the correct drugs in correct doses. So, if this chain or if these three are not maintained, it is very difficult. And this we have seen with the failure of NTP, with the failure of, I would not say rather failure, but the expected success of that RNTCP. And that's why every now and then we are changing diagnostic modalities, we are changing the drugs. The moment we introduce one diagnostic modality, we find there is a limitation of that diagnostic modality, then we try to back with that another test, and then we are inventing every year one more drug. Sometimes we are giving alternate day drugs regimes, daily drug regimes, extended duration, shorter duration. We are trying everything. Is because that what is the center is the diagnosis is not happening properly. Clinicians can correlate better. If the diagnosis is not proper, how will you treat that patient? The patient is getting motivated by everything, by the community, by the doctor, by the relatives, everything. Everybody trying to motivate the patient to go to the clinician. The clinician prescribes some investigations. Now, if that investigation is not up to the mark, number one, investigation is not available, or if the investigation is misleading, then what do you do? You treat the patient with hypothetical scenarios. You try to treat the patient with your gut feeling, with your experience, or what is given in literature in such situation. But that is not the exact treatment. It looks like exact treatment, but it is not the exact treatment. So that is happening with tuberculosis for decades after decades. And that is what I want to point out through UDST. So this is the missing link.
So one thing I add, what sir is told regarding that next generation sequencing. See, it depends upon the type of sample and the good sample. Say, if you analyze the last 2 years data, you can point out that recently clinical diagnosis pulmonary tuberculosis is increased trend as compared to microbiologically diagnosis pulmonary tuberculosis. Probably the reason behind this is the screening. We are using chest X-ray as a screening tool, right? But what I mean to say, even though patient having pulmonary tuberculosis, if patient is not able to give the good sample, so it might be also a result may be negative also. That's why what I need to see, we need to advocate the patient how to give, or we need to counsel the patient how to give the good sample for the test. That is what my message also.
Actually, I just wanted to add to what Dr. Shiv was explaining. For the targeted NGs to be really effective, what we need is a good functional program. So whatever gaps are there, those can be narrowed with the program functioning well, and only then a newer tool will be more effective. If the existing tools are not being used appropriately, then a newer tool is not going to be of much advantage. So very important thing is the NTP structure and the function. That is the platform on which any new tool can stand on.
Thank you, madam. And maybe if you allow me to add one more thing, because since we're discussing about UDST, so the one practical problem which we face means day in and day out, sputum comes to be positive, and especially in case of TrueNat, we encounter this problem with TrueNat, but rifampicin sensitive is indeterminate. So a lot of time is wasted here. Again, the patient is asked to give a repeat sample. And again, if it comes indeterminate, or again, if it comes negative, then we are in a fix, we are in a dilemma, what to treat or not to treat. So that data which you showed in your study, that the delay in initiation of treatment around 26 days or something, it was that. So again, this TrueNat, practically speaking, is contributing, I think, a lot of delay in initiating treatment. So I don't know if you can comment, or if anyone from the house can comment on this. Is this the same situation everywhere, or we are facing the only problem?
See, basically, what we understood that it depends upon the concentration of bacillus in the sample. So in TrueNat, probably rifampicin indeterminate means sample of bacillus is inadequate to identify the resistant pattern. So as per program, definitely we need to think of another modality of molecular diagnosis method like LPA, or even we can go for say liquid culture, so that you can identify the rifampicin status, aerial status. So what we used to do it in our as a clinician, suppose it come out to be a rifampicin indeterminate, we used to treat the patient as a rifampicin sensitive, but simultaneously we need to do the other molecular test like CBNet or LPA. Based on that, we can modify our treatment plan subsequently.
But program, there is no scope to enter, because there is no scope to enter rifampicin in the indeterminate. I think
Sir, actually, rifampicin resistance program has identified the test type. So only if that test type is permitted by the program, then only you can give the result.
I know that's
that is the problem with program. That is the problem with the program, because that same machine, TrueNat machine, we can also detect INH resistance, but program don't permit that.
And another
So-
issue, actually, our practical experience, I was saying, in our institution. So we do it, our department does, the particular department does AFB smear and also this CBNat, both. The fallacy of this not doing AFB in periphery, that there can be AFB positive, but CBNat negative. Because if you look at the NTM cases are increasing. I'm showing it yesterday, I think just now I was showing
Yes,
you.
yes.
Well, last 2.5 years, we have 60 NTM cases. Almost per month, we are getting 2 NTM cases. The other way, in particular coastal area, we have now 2 admitted cases of melioidosis, which comes as a TB, almost mimic TB, cavitary TB. I am showing Dr. Pothal today also. It's showing cavitary TB. So problem of other region, our region is quite different. Actually, we have to think. And today also I am showing madam, just now few minutes before, one patient was treating 4 months at ATT. And today I find to discuss that, I think Dr. Maheshwar was showing that with me. So that's so that it is nothing but it's a silicosis. It's a frank silicosis. Nothing changed actually. I just to counsel the patient. So problem actually multiple. So it has to clinical, CBNat, everything. But we should not forget doing AFB also. At least we should not treat NTM. We should treat or not treat NTM, because some NTM doesn't require any treatment also, only observation only. That's why I want to say that, because many people are treating. This also keep in mind. May not be very common.
Sir, to add to your comment, in our places also we are finding NTM cases, we have a lot of melioidosis cases. I'll share with one of my personal interaction with a senior lab technician. He said, "Sir, आप कुछ भी बोल लो, माइक्रोस्कोपी बेस्ट था, इसमें कम से कम बैसिलाई दिखता तो दुश्मन दिखता था. अभी now we are suspecting and giving treatment." तो this was his honest confession. Sir, माइक्रोस्कोपी एक बार करा लो. And they were challenging, many of the lab technicians challenges, sir, आप करा लो, you give a trial, that microscopy versus your TrueNet. Microscope, we are on the microscopy side and we are on the TrueNet side. But still, but then, you know, UDST has to be the answer, because once it is, you know, the gene sequencing, the mutation and the drug resistance, then you can defend your diagnosis at least. So that is also, you know, important.
Sir, I want to add last thing. Just, Madam has said in the peripheral setup where we are going for C in the CSC, whether they are doing effectively that TrueNut. Are there any method to sort out that problem, the deficiency of cartridges, deficiency of logistics? First thing. Second thing I want to highlight, whether there is any scope of doing active screening as it is being done, because we are not catching the denominator effectively. Then comes the diagnostic part, whether we will do effectively the diagnosis or not. But the denominator we are not catching. The presumptive TB cases, which, as you have said earlier, Madam also pointed, the program is not effectively catching the remaining denominators, which should be diagnosed. Then comes whether the cartridges are there, then comes the next generation sequencing, as my.
I agree to his point.
No, in the present scenario, we have identified hotspot areas. Recently, in that 100 days campaign 2.0 has started on World TB Day on 24th of March 2026. From that day onwards, the surveillance system has totally changed in TB surveillance. It has shifted from that passive surveillance to totally active surveillance. In that case, AI-based hotspot areas has been identified across the country. In our state, we have 13,271 villages and wards identified to be having more, expected to be having more number of TB cases. So, entire population of those villages are considered as vulnerable for TB. So we are doing that because now X-ray is being used as a screening tool. We are covering entire population more than 14 years, radiologically at least once in a year, screening them. If it is found to be abnormal, as Vera sir has also already told, that it is saying that it is abnormal. It is not saying that they are having TB. In that case, we are trying to collect a sample of sputum from that patient. If he is not able to give sputum even at any cost, in that case also that abnormal X-ray being reviewed by a chest physician or by a radiologist or by a clinician to confirm that the abnormality is not due to TB. So that is the way we are covering the entire vulnerable population. We are trying. As far as the total villages are concerned in our state, by this time, because we have the third highest number of villages in the country, we have covered almost out of 13,000, we have covered around 8,000 villages. So it will be around 60-65%. So we hope that by next 1 month we will be completing all the villages. Again, we will go for the second round of screening of those villages. So denominator will be covered in that way.
One additional support what we have is out of few vertical programs in India, TB is the only program where medical colleges are actively involved, like Behra sir also said. 834 medical colleges, practically all the districts have at least one medical college. So if UDST can be, or the facility of UDST can be made available at least in one medical colleges and state referral hospital, that should actually minimize the gap of the workload which we are talking. And I really appreciate your district that microbiologist training at tagging to each district. That is also a good initiative. So we can learn from each other like this kind of things.
I also pointed out here, in also our medical college, we have around 22 medical education institutions out of all are involved in actively in medical college in NTP. We are also following active case finding method in medical college, not only passive. What I mean to say, we called it the intensive case finding. Suppose a patient come to in our OPD having no symptoms of tuberculosis, like some group of high risk population like diabetic, HIV, past history of tuberculosis, alcoholics, smokers, malnutrition, irrespective of symptoms, we used to screen them for tuberculosis. Not only that, we used to screen we try to do it, the implement in all medical college, like all indoor hospitalized patient need to be screened. We are doing some medical college, irrespective of symptoms, even in orthopedics ward, if a patient is hospitalized, we used to screen the patient for tuberculosis. We are trying to implement it in a better way, but these are one of the challenges. But still we are going in, not only we are following the passive case finding, now we are acting also active case finding.
So for the who are present here, NTP guideline says not only symptomatic patients, indoor screening, bidirectional indoor screening means those who are having diabetes, HIV, or any other chest symptomatics, they should be screened for tuberculosis. From OPD, 10% of the population should be screened for tuberculosis. Not only symptomatic, asymptomatic and contacts of TB patients also should be screened for tuberculosis, which if properly done as per the guideline, should be a huge task and should actually reveal the number of cases. You are talking about the denominator, it should be even bigger number.
So probably, thank you so much, sir, for
Sir,
a
I
nice
have few
discussion.
doubts, sir. Practical questions. Sir, I'm working at some hospital. Sir, we are getting in extrapulmonary tuberculosis at times rifampicin indeterminate. By that time, we are having no other sample, like sir, lymph node biopsy. If biopsy already done, then what to do in that case?
Okay.
And another question, sir. Suppose a patient is on treatment, already taken 3-4 month treatment. Suppose spine, TB spine. We are finding some lymph node enlargement or during the course of treatment. This may be a case of drug-resistant TB. So in that case, they are asking if TrueNAT or CBNAT is not positive, you cannot say any sample for any culture or LPA. That problem also we are facing, sir.
Right. Coming to your first question, the indeterminate, actually, it's very often common, not that uncommon. But as regard to the extrapulmonary tuberculosis, once we get the opportunity, actually dictum is that if you get the extrapulmonary tuberculosis, sample should be sent for the liquid culture. That is the gold standard, particularly the extrapulmonary tuberculosis
Sir,
sample.
from the very beginning, they are not receiving, sir.
Okay. No, that's some, but the issue is that, yes, there are some challenges. We are like, as you told that in the mid, but you can follow the other method of modality of molecular test like CBNet also.
CBNAT, sir, we are doing here.
Was it? So the third thing what you have pointed out, the mid of the test, mid of the treatment period, again, think of that probably clinically we are suspecting resistant.
Yes, sir.
Again, sample is the issue. Once we got the sample, definitely, yes, some cases where even though patient having a TrueNAT negative or CBNAT negative, to our personal contact with our laboratory, they can do liquid culture irrespective of even though patient is TrueNAT negative. They can do it. But we need more, say, little bit personal communication to the
Yes, sir. We have
laboratory technician or a microbiologist. That can be done. That can be solved in the level also.
Thank you.
Upfront CBNet does not mean that you cannot send extrapulmonary samples for LPA. If you suspect such cases where you suspect that CBNet might be negative, you directly send to LPA if that facility is available. You can do that. Upfront CBNet means at least you should send for CBNet, which we are not sending or we are not sending.
Since our guideline is there, probably there is a lacuna with us because we are not giving proper training. I think in some hospital, they require some sensitization training for the other than the coronary medicine and the microbiology people. They require training. If the training will happen, definitely they will accept the sample. Already guideline is there.
Thank you, sir. Thank you, Dr. Datta, for your nice discussion. Next, we can move our next speaker. The next speaker is well known to everybody. He is a mentor of mentors. He is also a teacher of teachers. None other than our esteemed Padma Shri Professor Dr. Digambar Bhere sir. Sir will talk regarding the pitfall of genetic diagnosis in TB in clinical dilemma. Very good topic. Probably Sir will definitely have a good discussion with us. Thank you so much, sir. Actually, sir's, if you see the CV, it will take probably 1 week or 1 month to read the CV. Well known to audience. Sir. Sir, please start your lesson, sir.
Thank you, chairpersons, and good evening, all of you. So, during the next few minutes, I'll just try to discuss some points about pitfalls in the TB diagnostics and a clinician's perspective. I'll tell from the perspective of a clinician. I think this is the slide has already been discussed. As per the Global TB Report 2025, the India has about 25% of the global burden of TB, and specifically if you see the last line, that is the MDR or the rifampicin resistance TB, we again burn the burden of about 33% of the world burden of MDR or the rifampicin resistance TB. So roughly it is estimated that India has about 1,30,000 cases of MDR and rifampicin resistance TB. I think what this slide does not say about the report of the drug resistance survey, the first national drug resistance survey that was carried out in 2014-2016. So in addition to rifampicin resistance and INH resistance, which we are talking about, so there are also additional drug resistance. I think that is what is very important. So any, apart from the rifampicin and the INH resistance, so resistance to other first line or the second line drugs in the new cases of other tuberculosis cases. So it is about to the tune of 28% or about 25%. And in previously treated cases, this resistance goes up to 44-45%. So this is one thing which we never talk very often, or which we I do not know why we try not to give this figure. It is because we don't have got a survey, the type of survey we had done in 2014, 2016, like now we had done the survey of all the 13 anti-TB drugs. So that is not available everywhere in the world. So that is, I think, one important point we should know, which I will be discussing in my subsequent talks. So obviously the burden wise, although the overall incidence has come down, as you can see, the burden has come down by about 21% from 237 to 187, but still we had as you can see, the burden still we are reporting 27 lakhs cases of new cases of tuberculosis. Again, if you see again to highlight, this is the integrated diagnostic and treatment algorithm for the drug susceptible and resistant tuberculosis. You see, we only confine to tests for resistance, testing for INH and for rifampicin and for fluoroquinolone. The other drugs obviously we are not doing because of reasons well known to all of you. So if I have a pointer, can you have a pointer? So if you see here, I can show you, that means this is as part of the universal drug susceptibility testing. You see all notified TB patients, not whoever has not been referred, afford the rifampicin resistance TB test, all presumptive TB or the persons with the abnormal chest X-ray and the non-responders to any regimen, all the three categories. So they should be, 2 specimens should be collected, and then the resistance testing will be done to rifampicin, INH, fluoroquinolone or other drugs as needed, because that is just written as needed. But by and large, the program currently follows the resistance testing and then the flow goes on. So that my purpose is not to discuss that part, but what I am trying to say, we are only trying to focus on 3 important drugs, that is rifampicin, INH and fluoroquinolone. And then we have got obviously definitely a very well planned, well established system how our national program runs. And recently, the policy updates, you are again telling that means the universal drug susceptibility testing that has gone, but again by and large it is confined to these 3 drugs. And then the other things, that is for the treatment part, that I am not going to tell. Then therefore, what are the challenges which you are discussing and which we have discussed during the last talk? So the challenges are multiple, both the biological, it is the behavior of the mycobacteria itself. Then there are various medical, social and economic challenges. We had the highest burden of tuberculosis. There is diversity of TB epidemiology in different parts of the country. Then the multitude of risk factors, the economic burden. Then there are various administrative issues. I always try to keep this as an important point. Then the central and state funding issues, the public health response, the TB teaching and training in our medical colleges and institutions, that is also the great setback recently. And then we are very poor in the research on tuberculosis in our own country. So these are some of the important challenges that faces our TB control program. Here if you see the trend of the DRTB detection, which I was just telling, you just see I just gave you a figure of 1,30,000 expected. But if you see this part, in the year 2023, say for example, we detected only 63,000 cases, that is about 58% of the expected MDR-TB cases in the country. And then out of that, that if you can see subsequently, so this is just I have given you a reality check. So how do we handle actually MDR-TB in our country? So this is this slide is little older. When at that time the country had projected 1.10 lakhs. That was, now of course it is 1.30 lakhs. So in that we case detected about 58%, that is 63,000. If we take the treatment success rate, that is actually again not 100%. Not all TB cases diagnosed are treated. Not all treated cases are cured. Okay, so roughly if you take 72% of success rates, so this 72% of the 64,000 cases, that means we are now curing only 46,000 cases. So overall successfully treated cases of these 46,000 out of the 1,10,000 cases, so that is about 41,000 cases. So that means the unsuccessful outcome, or we don't handle or we even don't diagnose them, so that is about 68,000 cases out of those 1,10,000 cases. So that means undetected, untreated or unsuccessfully treated, that constitute about 61.9% of the cases of MDR-TB. So this is, if you go that way, this is what is a reality check. And then the diagnostic network has vastly expanded, starting from the national reference laboratories, we have 6, the IRLs we have got 37, and then if you can see at the peripheral level, district level, and then at different places, we have got lots of expansion in the diagnostic facilities in the country. But question is, even if we have expanded, are they enough? The diagnostic capacity of the country, are they enough? Although the program managers say yes, they are enough, and most of them are underutilized, but that is possibly not true. So again, you see, this is the about the NAT expansion. You can see the nucleic acid amplification test, whether it is gene export or whether it is true NAT. So that has increased gradually, and now it is about to nearly 10,000 NAT machines or NAT testing facilities are available in the country. But still with that, and you can see there is a very rapid scale up of TB laboratory and testing. You can see all types of tests like the microscopy, when we are using it very routinely now. Of course, as already been told, the microscopy is not the first line of investigation now, it is the NAT. And then you can see the NAT expansion has occurred year-wise, and then we are doing it more and more because every case is being tested as the first line testing. And then again, the liquid culture and the liquid culture DST facilities to newer drugs have been added. But question again is, although we have added, they are not sufficient, particularly the DST for bedaquiline and epitonamide that was planned with a goal of at least one certified laboratory per state. I am not sure whether this is it is still implemented or not. And again, you see the treatment success rates. I am just showing you the slide to see the upper blue line. You can see the success rate for the drug sensitive cases around 89%. And then the MDR or RR TB with the newer regimen, it is coming from around 50% to about now 83%. And the same thing with the pre-XTR and XTR TB cases. And the INH mono resistance case, the response is also quite good. And we have added up new diagnostic tests like the development of the MyLab Discovery Solution. It is a Pune-based company. It is a multiplex real-time PCR assay. So what I am trying to say, there are multiple things. The TB diagnostics have expanded from the smear and culture to the rapid molecular assays. And now, of course, we are coming the targeted sequencing and then the artificial intelligence supported imaging. The question is, choosing the appropriate assay in routine practice still hinges on the affordability, the availability, and the readiness for the scale up, and then of course the quality assurance. Most programs, that is export or TrueNAT, are preferred frontline assays because it is cost effective and readily available. Then cultures, line probe assays, and NGS remains indispensable at referral centers for full resistance workups. In spite of that, there are of course different issues. We all know what about the acid fast staining. Although it is rapid, cheap, and easy to operate with a high specificity, it is suitable for large scale screening. The weakness is its poor sensitivity, especially for extrapulmonary TB, pediatric TB, and patients co-infected with HIV. And again, its inability to distinguish between Mycobacterium tuberculosis and the NTM. So it can be used as a preliminary screening in a resource limited settings, and a rapid identification and follow-up evaluation of infectious patients has to follow with that. Similarly, we all know about the culture. Again, they have the lengthy turnaround times. There is rigorous requirement for laboratory infrastructures. As we are discussing during the inauguration in many of our medical colleges, because of whatever reason, they are not able to develop these infrastructure. And but the best thing with this is possibly the best gold standard testing. It has ability to distinguish the viable bacteria and perform the drug susceptible to testing. But again, it takes a lot of time, so therefore it is not suitable for regular day-to-day management of a TB patient. And again, it has the advantage of it is applicable to both pulmonary and extrapulmonary TB. Then serological test, obviously, they are the screening for active and latent infections. And the good point is a blood sample testing, but it is inability to differentiate between active and latent infection. And it is affected specificity by endemic regions, and it is unable to directly detect drug resistance, obviously. Then the rapid molecular assays like export MD, uh, export and then the TrueNAT, although they are very rapid, that can be done within 2 hours and easy to operate, and they are highly sensitive. There is a simultaneous detection that it says that it is empty Mycobacterium tuberculosis. It distinguishes it from the atypical mycobacteria. And again, it also says the rifampicin resistance associated gene mutation. But the problem with this test is that its inability to perform the comprehensive drug resistance profiling. It only tells about the rifampicin resistance, and it has a reduced sensitivity for extrapulmonary TB and a low bacterial load samples. And again, the issue with this testing is that it only detects the genetic material, that is the DNA, that says only RPO-B gene is present, but it does not say whether it is dead or the live bacillus. And then the second thing, as it was told, when the report, it is reported most often as indeterminate, or when it comes as the low or very low, then there comes the dilemma. However, it is very important to know that it's a rapid initial screening and the drug resistance risk assessment, the molecular diagnostic for resource limited setting, it is possibly very useful. As I told you, the pitfalls in the current diagnostics, that they sit fast staining, it has got low sensitivity. Then the mycobacterial culture prolongs it has, because of the slow growth, it takes time. The PCR based molecular assays, although there is rapid detection, the capacity for a resistance profiling is limited to a narrow set of mutations. Only it can say to which, whether it is rifampicin, if you are doing it for the second line drug, then it can tell about the fluoroquinolones. Then, however, the next generation sequencing, which we will be discussing little later, where they are some of them are culture independent tools, although the whole genome sequencing still will require the culture. Then the broad spectrum pathogen identification is possible. It has got added value in the complex scenario, including the extrapulmonary TB. It can also detect the mixed infections and infections in immunocompromised hosts and the pediatric population. So the new near point of care, these things, particularly the next generation sequencing, the swab-based molecular test, particularly now there are many swab-based molecular tests. They have got many operational advantages. They improve the accessibility and the cost. Then sometimes the loss of sensitivity miss the lowest positive molecular signals. Sometimes, as we are talking about the trace export MTV or a reach ultra sputum test results, so they represent a TB disease, even if not confirmable by culture. Even in some cases, you may not be able to confirm by culture because of technique, or because of, again, you don't have a sample, as somebody was telling. So the underdiagnosis will be greatest with the mild disease. So even if you are treating mild disease, you are not doing any harm. I think that will be the answer to that question. I think one point which Dr. Mahapatra was telling, another disadvantage with just treating on the basis of smear positivity. This is just a recent study from India. As you can see, this is a very, very large sample study that is published in Lancet just recently. This is a study over 70,000 patients who have got presumptive TB, and you can see about 0.32% had NTM disease. So out of them, about 190 were pulmonary and 39 were extrapulmonary. So even if they are smear positive but CB0 negative, so you can see they can be NTM disease also. That is has also been shown from this country only. So we have got, these are the, if I summarize for you, these are the new frontiers in the TB diagnosis. So these are the current and emerging technologies, like of course the export MTV RIF and export MTV RIF ultra assay, then the urine lipoarabinoman LAM assay, then the computer-aided detections, then the cytokine signatures and biosignatures, nanosensors. So this is all actually science, but this is not, true. All of them are not true for the programmatic conditions. So these are the things we have already discussed, whether the spectrum of TB infection can be a latent TB, then can be subclinical. That means the patient has got no symptom, but still he has got disease somewhere. But if the active disease comes only, he is having symptoms and a transmission. So then different type of test can be positive or negative, depending upon uh, whatever and how you are trying to apply that test. So these are the summaries of for the various diagnostic arena. Now we have got starting from the symptoms, radiology, microscopy, then to diagnose latent TB we have got IGRAS, tuberculosis skin test, etc. And then the multi-drug resistance TB, we can use the techniques as I have already told you. So this is some of the new tests they have come up, like the swab samples you get simply from the swab, and then with a good sensitivity and a specificity, it is very rapid, affordable, and easy to use diagnostic testing. So this from the swab test, it met the WHO targets for diagnostic accuracy and usability for tuberculosis detection across diverse clinical settings. So these are the study has done from India also. So even if you don't have got the sputum, you can just simply take the swab from the swab from the mouth. That means this is just like a saliva test, and you can do it. But now coming to the talk which you are talking about, the genome sequencing, the whole genome sequencing that generates basically the DNA sequence data for the entire M. tuberculosis genome, which can be used for various applications in tuberculosis prevention and control activities. So we can have three different ways of whole genome sequencing as I understand. One is whole genome multi-locus sequence typing. The second one can be whole genome single nucleotide polymorphism comparison, that is what is the targeted one, and then the detection of possible drug resistance. The whole genome sequencing involves the sequencing the entire genome. I think tomorrow the experts are going to tell you much better and in a much clearer term. That provides a comprehensive view of an organism's genetic makeup. On the other hand, the targeted sequencing, also known as the panel sequencing, it focuses on the sequencing of the selected genes, typically ranging from a few dozen to 1,000 of genes. So this is what is the targeted sequence. So this is how the flow goes, but again I am sure you will be hearing these things more clearly and more vividly tomorrow. So the WGS, or the whole genome sequencing, as the primary diagnostic tool that simultaneously detects and confirms that it is MTB within a culture from a clinical sample. It identifies the potential laboratory processing contamination events, ensuring treatment is not given to patients that do not require it. It predicts the drug resistance patterns, ensuring appropriate treatment, provides a high resolution of TB strain relatedness to trace infection sources and potential transmission network. So the helpful in the epidemiological testing. So the genotypic drug susceptibility has got the genotypic drug susceptibility testing for assessing the local transmission dynamics, the programs reported for the analysis and dissemination of findings, role of multidisciplinary team for interpretation and system for multidisciplinary data analysis is a great disadvantage for this, because it gives you a whole set of data. So you need a bioinformatics system for this. This is one disadvantage of the whole genome sequencing. So their utility in the control programs, although is increasingly performed, however there are uncertainty about their optimal integration into the real-time public health practices as we are discussing just before this talk. Then the transforming the tuberculosis diagnosis with the clinical metagenomic is another method of this genomic diagnosis. So it achieves moderate to high sensitivity. There is excellent specificity in the diagnosis of tuberculosis. The diagnostic performance is often constrained by low mycobacterial rate counts, interference from abundant host nucleic acids, inability to distinguish active from latent infection, and accuracy of drug resistance prediction remains limited. So WHO currently only endorses the targeted NGS as the preferred sequencing based approach for resistance profiling. So, we have got in India, I think as I told you, we always adopt things which are coming up. So we have got the Indian Tuberculosis Genomic Surveillance Consortium, and the team is here. So I think they are going to tell more about that and how they are going to helpful, what data they have obtained so far. But that is a good development, and also a group of experts has, way back in 2023, it was predicted that the genomic revolution that is going to transform the TB diagnosis and treatment with the use of whole genome sequencing. So that was a conscious statement, and I think at that time the experts had asked the TB control program to think about this and to adopt that for the future use. So this is just one study from the whole genome sequencing from India of clinical isolates from tuberculosis patients. That is a real world data that indicates a high proportion of pre-XDR cases. This is the microbiology. This is, as you can see, what you see, this is a group of patients which are studied this whole genome sequencing. As you can see, in that population, a large, what I am just trying to tell you, a large number of drug resistance apart from MDR, XDR or pre-XDR are coming up. As you can see a large host of drug resistance could be identified in this studied population, which otherwise could not have been done because usually we don't do culture and DST in every case. The metagenomic NGS which I was telling you, this technique that analyzes DNA from the entire microbial communities directly from their natural environment. It may be soil, it may be water, or it may be human gut, without the need to culture. This is the difference between the whole genome sequencing and the metagenomic next generation sequencing. And there it will extract the genetic material from the environmental samples and sequencing them. That means all types of organisms present there, they will be sequenced. And there often and it runs all the nucleic acids in a sample to identify and quantify the microorganisms present. It focuses on specific genetic markers within the microbial communities, any specific genetic marker. It provides insight into the diversity and function of the microbial communities, so which is crucial for understanding the ecosystem and the human health. So this is how it is, all types of sample it can be used for this study. The targeted NGS that simultaneously it will detect the multiple drug resistance genes. It enhances the detection sensitivity and specificity of specific target sequences, and the WHO has already approved the genotype drug susceptibility testing for TB. However, the weakness, it has got a narrow pathogen detection spectrum, and it has inability to identify the novel or rare mutations which are not already targeted. And the applicable scenario will be this comprehensive assessment of TB drug resistance to rapidly guide the individualized treatment. The whole genome sequencing, on the other hand, it is the strength, it provides the whole genome information and a theoretical identification of all drug resistant mutations and the strain typing, the epidemiological tracing and resistance mechanism studies possible through this WGS. However, the weakness it has insufficient sensitivity for the low load samples. The data analysis is quite complex. It has a longer turnaround time and of course it has got a high cost. However, the advantage of whole genome sequencing is molecular epidemiology and the transmission tracing of the drug resistant TB, then the complex drug resistant TB cases, and then of course the research applications. The metagenomic NGS, it has got short turnaround time, it has unbiased broad spectrum pathogen detection, it increases the sensitivity and specificity for pulmonary TB, extrapulmonary TB, and TB in special populations. It identifies the complex and mixed infections. As I told, it detects all types of organisms present. It is interference-free detection, performance during short term, say for example within 3 months anti-tuberculosis treatment. The host transcriptional information also is available to screen the early TB biomarker. However, the weakness, they are expensive, and then they have intricate operation with multiple factors affecting detection assays. Then the potential of interference from the host nucleic acids. It is inferior detection speed to rapid molecular techniques. It is extremely complex result interpretation, inability to differentiate between active and the latent infections, and pathogenic or colonizing microorganisms. As I told, all types of organisms present in the sample could be detected, and it is ineffective in predicting the antibiotic resistance. So it can be used for the traditional tests when the traditional tests are negative, but Mycobacterium tuberculosis infection cannot be excluded. Then it is under suspicion, when you are suspicious of co-infection with rare or atypical pathogens and clinically suggestive of extrapulmonary TB such as disseminated TB, tissue or lymph node TB and urinary tract TB, etc. So those samples can be tested. Then critically ill patients, immunocompromised hosts, and patients with complex infections of unknown etiology. So it has facilitate the novel diagnostic strategies, and it combines the pathogen detection, as we said, with the host response data. It has broadens its potential clinical utility. However, the practical barriers we have talked about: high cost, complex laboratory workflow, difficulties in data interpretation, and it continues to restrict the widespread adoption in routine practice. So the future efforts should prioritize the technical optimization for this. So this you can see from different samples and different organisms will be isolated. So this is the comparison of all the 3 techniques. This is one study that in comparison to the using the MTB culture as reference standards, you can see the gene export, the metagenomic NGS and the targeted NGS. You can see, so they have got different types of the sensitivity and specificity. So they are not even again all 100%, although they are technically useful. I'll just pass on to this is what the presentation of WHO recommendation. So this is the critical. So there is a critical need for the better and faster diagnostic for drug resistant TB, as we discussed during the inauguration, during the previous talk, and also some of the disadvantages of various tests as I enumerated. So there is the advantage of these neurodiagnostic techniques for early detection and optimal treatment, which is critical for tackling tuberculosis. New drugs and certain regimens are now available. So we have to get people on the right treatment from the very beginning, from the start, and preserve the efficiency of new drug regimens so more people can avail of this treatment for as long as possible. So the targeted NGS based their diagnosis of drug resistant TB that directly from the clinical samples present a paradigm shift. That is what is recommended by WHO. There is a strong genotypic testing in comparison to it has got a very good correlation with the genotypic and phenotypic testing for the tuberculosis. It is adaptable to new genes and the mutations. It is scalable, lower biosafety requirements, and then the multi-disease platform. It is faster results to inform clinicians about its decision making. And then it generates, of course, it is what is needed is to generate evidence, for which I think we have got this conclave, and to boost in-country capability to support the global adoption of end-to-end targeted NGS solutions for comprehensive diagnosis of drug-resistant TB. And then again you can see there are two platforms, that is the GenoScreen Illumina and the nanopore technology. They are available, and you can see this is the result. You can see there are the 12 drug resistance, the sensitivity and the resistance pattern can be known. Actually it is a 14 drug sensitivity or resistance, as the case may be, can be available from this. Similarly with the other platform, that is the ONT, the accuracy, with this accuracy you can see that is when they are compared with the gold standard, that is the culture method. So it is very important to see that from evidence to the policy of the NGS for the patient care is required, and therefore we should move from policy to implementation, how it should be done. So it is in fact it should be acceptable. It is I am sure it will be acceptable because it is comprehensive, it is convenient, and it is rapid and adaptable. However, the challenges are the setup, high technical complexity is there to start with. It has a specialized infrastructure and expertise required. The procurement and the supply chain is again very essential, the way we are experiencing with the currently available technology with our program. So we should be careful about that. Then the data management and storage, and then the routine update of the mutation catalog. That means as we get more and more mutations or the resistance pattern, we have to then create the new catalogs from our clinical experience. So the values, preferences and equity considerations are required. Then implications for access-based should be required, and of course we have to take into account the affordability and the cost effectiveness. So, in conclusion, actually what they have concluded, the various studies has concluded that these targeted NGS that was found to be cost effective depending on the context, and the costs will vary by the prevalence of resistance, current standards of care, potential impact of loss to follow up, and the implementation approach. So if you take everything into consideration, it seems to be cost effective, and this test was acceptable and implementable in routine programs, in routine program conditions despite inherent complexities. So optimal implementation models and algorithms will be required. I think this is a good start as we are meeting here. So, but only thing we have to be very careful that translating mutations to resistance information is very important. The WHO now endorses this technology for direct from the sample resistance profiling across more than 10 drugs. But we have to be very careful. I think that I will again repeat that this targeted NGS identifies mutations, not resistance. They are not the same thing. So the clinical interpretation is essential to translate mutations into actionable treatment decisions. Not all mutations confer resistance. Some are benign, some are uncertain, others indicate high or low level resistance. So accurate interpretation is central to effective drug-resistant TB care, but it requires standardized tools and practice guidelines. So, and with then there are the mutation list are being upgraded, and that I am sure you will be hearing it tomorrow in more detail. So these practical consideration for this NGS implementation and the scales. So one has to assess the country's readiness, the technical and operational guidance is required, training. We require all these preparedness before adopting this technology. So ladies and gentlemen, thank you for the kind attention. What I try to talk to you about this new technology, of course, I don't have got much experience with this, but we have to take everything into account. This is something which is new. We'll know, as I have told earlier, we will be able to know about to which drug the mycobacteria is sensitive or resistance, and therefore we can take and treat the patient accordingly. But even if we know, suppose I know, the other thing we should be very careful is, say for example, I know that the test is available now, 5 drugs are resistant. So it may not be same for every patient. So which drug, which regimen I will prepare. So it will be little complex, the decision will be little complex. So the clinician should be very efficient. He should identify actually a regimen, like we do in case of lung cancer case, like targeted therapy. So I don't think things will not be that easy for, for tuberculosis, although it is now easier for diseases like lung cancer. You know that this gene is there, so I give this drug. But for this, the things will be more complex, and I am sure we'll be trying to overcome that when we face this. So thank you very much again for your kind attention.
Thank you, sir, for nice. Thank you, sir, for a nice deliberation. Also, particularly pointed out comprehensive way, as well insight to the next generation sequencing. Due to the lack of time, I will request the audience to, we can take 1 to 2 questions from the audience, so we can discuss in a better way. So, some queries, sir. For example, sir, in next generation sequencing, what about the sequencing, genetic sequencing we have? So, suppose we can identify some of the rare mutant variety also. Does it reflect the clinical significance?
Same dilemma I put it to you also. We should be careful about that. So therefore, actually now the WHO have made it all open, and then everybody is asked to put into their data, and that we have to mix the two things, our clinical experience, as well as this suppose mutation X we detected. So we have to interpret whether it is really important or not. So many, as I told, many of them may be just benign. They may not have got any clinical significance for the patient. So we have to wait for that, and we have to see for that, how it is coming out in future. So that at this moment is a question.
So probably time will say that exactly we are in the right direction. Thank you so much, sir. Please kindly taking the seat. Next, I will request our next speaker, Professor Durga Madhav Satpathy, sir. Fortunately, sir is also our Director of Medical Education Training in Government of Orissa. Second part, beauty of that sir is also our Operational Research Chairman in State Task Force in Orissa, NTEP. So I am request, sir, Professor Durga Madhav, sir, to give some points or to our august audience regarding our present NTP as regard to Odisha as well as way forward. Thank you, sir. And
thank you, Professor Sudarshan and Dr. Ajay, respected chairpersons and dear delegates of this important conclave of policy making, especially policy and decision on tuberculosis. known since ages, still a public health problem. Sorry, I was late. And again I tell sorry because I have to again rush off for another counseling for tomorrow as the Director of Medical Education. But one thing I am to say that in epidemiology, the three things, agent, host and environment. As far as the agent is concerned, as my previous speaker sir has said, so much about genomics. And me being a public health person of community medicine, I am more concerned about the host and environment. From time since control to revised control to elimination at present, and the vision of our Honorable Prime Minister of a TB Mukt Bharat, we have to traverse a lot. And here, though government is supplying everything, we have CBNATs machines even at the sub-district level. We have all the drugs supplied by the government free of cost. Nowadays, if one writes an anti-tubercular drug, then also he or she is questioned by the pharmacist and the district. So we cannot prescribe even, because all the drugs are free in nature. We have many schemes for that. Especially as far as data is concerned, we have the Niche portal. And for their upliftment, especially on the nutrition, we have Niche Posan. But still a lot of research has to be done. Especially operational research, because I am coming to this because I am the head of the operational research OR chairman of the state. I think I have to leave this post also because of my other commitments. I am not giving the adequate time, but we need research. Is handing over the money in Niche portion better? Or should we go for cooked food at least 3 times a week? Which is better for upliftment of the nutritional status? Needs research. Lot of NCD burden. And we know that tuberculosis, Mycobacterium tuberculosis is a latent infection, especially in the NCDs, especially among diabetes. Is it so? We think that tuberculosis is a common disease among the lean and thin people. Diabetes are not thin, but still it plays a latent infection. That also needs research. These are the host factors. Environmental factors. We have Ujala scheme now. We are telling people not to use biomass fuel in their households. They have doors and windows. If you have seen the community, they have doors and windows which are usually closed. So, does indoor air pollution lead to this infection? Many things has to be told, explored. And for this, our government also has a policy that we give our students a fund for research on the thesis topic related to tuberculosis, which amounts to nearly 30,000. At least one, we have 2 theses per college At least one project should come out from each medical college and hospital, so that we can also encourage our students, the future generation, on tuberculosis and do a research. Similarly, as far as other proposals are concerned, it is placed before us. We submit to the State Ethics Committee and get it approved if it is tuberculosis. If it is tuberculosis, I am behind that. Approval by everyone is done, because I will pursue that. Because now the age has come that we do not want to see the problems. Of course, we want to see the problems, but we want to get the solutions from you for that particular problem, which will help us in formulating a policy for improvement of the conditions of the people, and we can achieve the dream of elimination of tuberculosis from our country by 2030. So, ladies and gentlemen, my sincere request to all of you that we conduct practical research which will be really helpful to the community. The person suffering from this dreaded disease in a remote village of our state, of our country, so that he or she is cured and gets back to work, becomes productive. Because as per definition of WHO, apart from social, mental and physical health, he or she should be productive in nature. And we want that particular person to be productive for our country. So that will be my request. Please conduct these operational researches and give us the solutions so that you can move ahead. Especially Dr. Arghya can move ahead because being the state tuberculosis officer. We want this to conduct operational researches on this important public health problem, and I wish that I get more and more number of applications on OR for our state, so that we can do further studies and find solutions. Thank you for your patience hearing. I said I will be brief because I have to rush again back to the office. My office is not yet closed. Tomorrow I have counseling again for SRs. Thank you everyone. Thank you.
Thank you so much, sir, for your valuable time giving us, because we know you are very much busy being a director in medical education. So thank you so much, sir. And finally, also we are very much thankful to the organizer giving us opportunity to being here. Thank you so much.
No. Now request, thank you so everyone for such an insightful session. Now I request our chairperson, Professor Dr. Sudarshan Pothal sir, to felicitate our speaker, Dr. Shivshankar Datta sir. Now I request our chairperson, Dr. Arghya Pradhan sir, to felicitate our speaker, Padma Shri Professor Dr. Digambar Behra sir. I request our chairperson, Professor Dr. Sudarshan Pothal sir, to felicitate our speaker, Professor Dr. Durga Madhap Satpathy sir. Now I request our organizing chairperson, Professor Mahapatra sir, to felicitate our chairperson, Professor Dr. Sudarshan Pothal sir. Now I request our organizing secretary, Dr. Sorin Bunia sir, to felicitate our chairperson, Dr. Argya Pradhan sir. Thank you so much, everyone. I would request everyone to be seated as we'll be having our cultural program soon. Please be seated.